Thank you. Starting with agenda item 1, apologies of absence. We've had apologies for absence received from councillors Anne Styron and Councillor Gerard Hargreaves. Declarations of interests. Does any member have any interest to declare? And moving on to the minutes of the meeting held on the 30th of November. The action tracker and the minutes of the previous meetings have been circulated. Does the committee agree to sign them as a correct record?
Yeah.
And moving on to agenda item 4, the voluntary and community sector development investment programme. The purpose of this paper is to update the Select Committee on public and health and communities team's proposal for a 3-year voluntary and community sector development investment programme of 2.35 million. This was the leadership on the 7th of February, and this is the committee's opportunity to influence the decisions. I'm Riley, Director of Public Health, and Callie Wilson, Strategic Director of Partnerships, Communities and Transformation, are to present the report. And we've also got Josh Rendell, our lead member, and Sarah Hammer, lead member for Community Sector.
Great.
Do you want to start?
I can start, and Karen can comment. So yes, we'd like to. This report is a decision that the leadership team is intending to make next week on the 7th. And we really appreciate the committee's views, etc., on what we're proposing. So, as you've said, Chair, is that £2.35 million investment in our voluntary and community sector, especially in wards that we see a bit of a differentiation in their health outcomes. So that's wards North Kensington and the Chelsea Riverside as well. We thought this is the best way to help improve health inequalities in the borough by working with the voluntary community sector, who are based in the community, who know the community extremely well, about offering them a chance to kind of influence debate around healthcare, but also offer them training as well. So over the future years, they'll be able to take this up as a bit more of a mantle and improve their lives with outcomes in the public health manner as well. And it can cover all things from obviously encouraging people to get screenings, immunizations, and other mechanisms as well that may be able to.
And just add to that, I think we all acknowledge the importance of our voluntary sector organisations and the reach that they have, which people will engage with them but won't engage with the council or the NHS or other. Yeah. So I think it's really, this is really important because we are, I think, tackling health inequalities is a real priority for us now. And we have certain wards which we know we really have to do something. We have a lot more data than we had before due to public health and their updated GSNA, and also through the work on the Grant Partnership team. So this is a really good opportunity, I think, for us to do something a bit different. And yeah, so I hope you will all support it. Any comments or suggestions?
Thank you. Callum and Arjun, if you want to take it.
So basically this is a new way of working. It's a partnership between ourselves and the community directorates, but it's also a partnership with our communities and with voluntary sector organisations. Over the past 6 months, we've been having a number of conversations in the community with voluntary sector organisations, with local people about some of the challenges to health and wellbeing. Alongside that, we've also looked at our GSNA and we've gone back to the evidence. So we've been looking at what are the healthy life expectancy challenges that we have locally. So we particularly looked at the life expectancy gap. We've looked at what are the contributing factors towards that life expectancy gap. And we've thought about the types of interventions that we need to put into place to support people to live healthier lives. This is a 3-pronged approach. The first prong is about a network, creating a network across the voluntary sector organisations. The second element is around the training offer that Josh mentioned. And then the third offer is about 3 years support, financial support to develop and co-produce with us public health interventions that can be delivered within the community. So again, that lends itself into this what we're doing differently and what's a new way of working with this.
No, the only thing I'd add to that is the inequalities that we know have been long-standing. So this isn't new inequalities that have suddenly developed, and what we are attempting to try and do is to think about why existing interventions perhaps haven't had the effect that we would have wanted to on the data. And what we're looking to do, as Anna and colleagues have highlighted, is to be able to better identify, better focus on those groups who need that additional support, to see a change in some of those figures as we want to in a positive direction, whether that be based on geography or people's backgrounds and everything else. So it's about identifying who we need to target and support, and trying to find organisations who people trust, who they feel comfortable with, who are based in that immediate vicinity, to be jointly accountable with us to try and make a difference, and trying to see if that moves the dial.
Thank you. And thank you. I really welcome this paper and partnership. And I think obviously seeing the figures on inequalities, which I think we're all aware of and aspire up to in terms of health, are really worrying, and that there's going to be additional work that's slightly different around this is very welcomed, particularly in the wards that are highlighted. I think, I know a lot of us have questions on this, but I think a good place to start would just be to sort of understand the timeline of this a bit more. As I know it's a 3-year funding plan, but sort of when we might be able to start by seeing this implemented, and what that looks like. If there's going to be following leadership, there's going to be a bit more additional information in what this plan and strategy looks like that maybe the committee could also see, and what success looks like. Just be a good place to start.
So timelines, we're looking at starting towards the end of March, April, once we get a green light to move ahead. So the first phase will be to continue those conversations with the community and with our voluntary sector organisations. We're particularly keen to do some market warming with them. So some sessions that will basically explore the types of interventions that we're keen to see more of in the community, to hear their ideas and what they think would be effective in the community, and to start to map out some of the referral pathways into NHS services, into council services, and services beyond health. So some of those wider determinants of health, so into housing, into education, into employment, around debt and support for those as well. Once we've gone through that sort of period of market warming or further co-production, the plan is that we will be looking at about September time to be considering moving towards the kind of the bidding stage for this. Reason why we're not thinking about that until September is we'll also want to do a training needs analysis with the voluntary sector community. We'll want to draw out the training support, which organisations will be providing that. We're recently recommissioning the lifestyle services, and one of the roles of that recommissioned lifestyle service will be further training support within that service. But there are also other organisations like the Royal Society of Public Health, etc., who provide a range of training courses that we want to have on offer. Also, when people apply, one of the conditions will be committing to that training offer and committing to the network of organisations who will be joining us on this journey. And then the plan is that we'll work with them in depth over that 3-year period. So in year 1, it might be that organisations will think they'll do a little bit of brief intervention, maybe around, say, stop smoking. Year 2, they might decide that then their staff will be trained to deliver stop smoking services. And then in year 3, we will be looking into and seeing that reaching into the communities that currently don't take up our services, or so we'd look to see the number increase in those ways. So when you're talking, Councillor, about how we're going to measure this, a lot of it will be looking at those referral routes into services. We know there's elements that we want to increase locally. Immunisations, one we talked to the committee about before, screening, particularly into our cancer screening services, NHS health checks, and then likewise referral into our public health services, referrals into some of the NHS services. And we're particularly looking at the reach of those services as well. So we're looking to see the communities and the groups we've identified in this report in greater number within our services. So we're looking at a much more culturally competent offer, maybe than we had previously seen. We're looking at a much richer relationships with voluntary sector organisations and with communities. And what we'll hope to see out of that is some movement in terms of health outcomes. For example, we know that Black women cancer is detected much later and their outcomes are much poorer. So, for example, some of what we'll be looking to do is to have those conversations around cancer, some stigma related to cancer, some cultural barriers. We know in terms of accessing our screening services, particular groups have raised with us concerns about those services, about what their own barriers are to accessing those services. And what we'll be looking to do is to go on a journey with those community organisations to address those concerns and fears, and looking to see our numbers increase. So we'll be looking at having a dashboard that will map out those indicators I've talked about to help us monitor over the 3 years.
Okay, that was really helpful to understand more. Portia, I know you have some questions. Do you want to ask on the sexual?
I think we've had these statistics for quite some time about North Kensington and Chelsea, or health, the state our residents are in. I mean, we've had over 5 or 6 years based on reports that I've written. What are we going to do differently this time to get a better outcome? Because we cannot keep studying. We're supposed to know who the vulnerable people are and have services provisions to deliver as we speak. And I would be very interested to know how trained are the community champions? What do they do? What's their job role? What's the description?
So I think with community champions, they're more an information-based group, if I'm right.
Yes.
They don't actually deliver health checks. But maybe in the future they can be trained to do that. I think we've got different groups that deliver different things. I think after Grenfell we commissioned some services which together for Grenfell, which were culturally appropriate and reached people that we could not reach. And I think this is just taking the learning from that and taking it further. We know that we can't, we're not trusted by a lot of people. So finding the right organisations is really important, because that's the only way we're going to address this.
I don't know if it's you. I would also like to talk about, you said you want to tackle inequality in health across the borough. Now, how are you going to do that if we don't have certain resources in the north of the borough? And we've got a cost of living crisis. How are people going to travel outside the borough? I mean, even for sexual health checks, where do they go? There's none in the north of the borough.
Well, this is what this is all about. This is making sure we have the right things available in the right place.
I think we've got a lot of opportunities at the moment as well with our integrated neighbourhood teams. So the changes that are happening within primary care. So it's an opportunity to have conversations with the NHS services, with voluntary sector services around other services that could be provided in the heart of communities and voluntary sector organisations. Are there known locations in the community that we can bring services to? That will mean that we'll be reaching the right people. So part of the opportunity now is with the new relationships with primary care, with this funding, which is significant, into the voluntary sector to undertake training and to give them support and money to run those services, which is separate to the little funding that they get through other avenues within the council. And it enables that opportunity to dig a little bit deeper into some of the cultural concerns that people have with accessing some of our services. So there's a whole range of different types of inequalities with services. So one of them being around access and ensuring that the right people are accessing the services and we're reaching the right people and having conversations with the right people. And this is one way of trying to extend that. Our community champions are absolutely brilliant, but they are volunteers. So they support us very much in awareness raising and having those conversations with individuals. But this is about local voluntary sector organisations providing public health interventions and being supported with training and funding to do that.
Thank you. And just one more question on this paper. Page 12, 4.22. This Public Health Commission and Turning Point, which is the SASH. Now, this organisation is based in W1. I was wondering how are they going to be able to support W11, W10, and the South Africa Borough? If you actually type in the chat, they say put your postcode and then someone will get back to you. What if this was an immediate response that I needed? So I don't understand that.
So Turning Point is one of our providers locally for substance misuse services. And they work in partnership with our other providers as well. One of the things that we would hope to do, so how I see this working in the future is Turning Point is one of our Public Health Commission services. And one of the purposes of this is to strengthen the relationships between voluntary sector organisation and those Public Health Commission services to make sure we're getting the right people through the door. So part of when I mentioned earlier around pathway mapping, we'll be doing work with these Public Health Commission services and other council commission services to really make it clear what the pathways are. So when there's a voluntary sector organisation who's having conversations with people where it becomes clear that substance misuse is a part of the issue that an individual or their family are struggling with, then they'll have that pathway to refer people back into those services. Also, Turning Point do quite a lot of outreach in our community as well. So there will be the opportunity for that outreach to be within a voluntary sector organisation if we can make that relationship work. So they're the types of relationships we're trying to generate.
And it's in the paper as an example of a particular type of intervention for a particular type of need, rather than the types of examples that we're suggesting that we would fund going forward. So, you know, to your...
Are we talking about SASH chair that's situated in
Yes,
Bordeaux Street,
Yeah, so if we're thinking about whether it's from a geography basis or whether it's from particular different types of communities and ethnicities, what we're suggesting of doing here through this leadership team paper and select committee paper is to identify some of those key areas where a bespoke, localized intervention that is accessible, that feels accessible, that will enable people to access some of those universal health services that they haven't otherwise. That we identify where they are, we place some of these interventions, and we train up some of those organisations that are already rooted in those communities to be able to deliver interventions like this. So that's an example of a particular type of intervention for a particular type of need that we need to then, through this work, map on to the particular areas where we know the sort of pinch points are.
I think Turning Point is I don't know how many places it is already operating in the borough, but it's definitely in SW10 where it's got quite a big centre. So I assume that might be a headquarters to W1 part, but they do have operations.
Quite a lot of those organisations, actually, the head offices in W1 or wherever.
What I'm trying to say is that the service, how you access it, you have to put in your postcode and you have to wait for someone to get back to you. I would have thought that you have a phone call, someone can pick up on the line to talk to someone for sexual health support. Drugs and alcohol well-being, sexual health support. So those two, okay, presumably they go hand in hand. But what about those who have got sexual health needs, but they don't take drug and alcohol? How do they access that service?
So if somebody had a sexual health needs, it would be through our sexual health services. So
where is that?
So at Chelsea Westminster Hospital,
Okay.
we have a base there. People access sexual health services in different ways. Increasingly, there's been more appetite for online accessing of sexual health services and for testing to be offered online. That's convenient for some people's lifestyles. Alongside that, sometimes people like to go to some of the central London services to access services there as well, or services closer to where they work. It is an open access service. And also we commission sexual health components of that through our GP practices as well.
That is, I understand that GP practices do offer that. What about those who do not want to go to their GP practices?
This is the
But they
point.
want to
This
do
is
sexual
the
health
point,
clinic.
Portia. This
Yeah,
is exactly
That's
what we
what we want
want.
to address through the.
Yeah, this is exactly what we want to do, is to address the people that will not go to the GP or wherever it is that.
Because what you'll find people just stay home and don't,
Yeah.
go to their GP practice because of fear, or because they just look. We cannot walk into St. Mary's. The one in St. Charles has been closed for how many years? And then they'll have to travel all the way from the north to the south of the borough. They have money. How do they get there? So these are, what empty buildings are there? How much would it be to commission?
This is what
This is why I'm
papers
asking
about.
the question. I don't think I'm having a, but I'm just really puzzled if we're gonna tackle inequality.
Mhm.
That's it.
Yeah,
Thank you.
No,
Mona, I'm going to move on to you.
Yeah, so if I understood it correctly, so it's those particular areas where people either don't have confidence in or trust in traditional NHS and health interventions, seeing whether or not those interventions can be delivered by sort of the
Yes,
more
that's
trusted,
right.
familiar. And just, you mentioned something about a bidding process, and is that, I was just wondering, maybe it's relevant to the question about which specific VCSs are going to be identified as appropriate for this work. Like how are you going to quality assure, and what are the respective areas of specialism for them? So what are the areas where people are, I think, sort of we heard a bit around immunisation, for example, where people don't have faith in, traditional medical professions. And then finally, I think this is potentially a really valuable and innovative and important piece of work. I guess the concern which I would always have is that the only way to meaningfully address health inequalities is to address the inequalities, and sort of health interventions are probably getting in there a bit too late. So what additional work might be done upstream, not just about sort of individual behaviour change and education, because those may not be where the evidence shows that it has the biggest impact, and specifically thinking about employment opportunities, and also just that feeling of, this is probably going off on a tangent now, but that feeling of well-being comes from a feeling of connectedness with your community, and all of those things will then feed into how motivated people are going to be to look after themselves.
So on a really good point, Mona, there, because I think not just, obviously this is just one step in the overall tackling the inequality element. And I think what the recent census did as well was kind of expose that a bit more, a bit more understanding. So obviously this step forward in better public health measures, better public health interventions, obviously just one of those steps. What you rightly say about employment is also correct, because both for Goulburn Ward and Chelsea Riverside Ward, we have about 47% of the entire resident population that are economically inactive as well. So how we can improve their kind of employment circumstances, or feeling more part of their community as well, because that's half the battle in a way as well. It's just ensuring that you have in yourself the ability to kind of feel part of something more, rather than perhaps just not having anything to look forward to. Basically, and employment can bring a lot of that opportunity as well, or voluntary sector work, etc., like that. So Callum's team and Sarah's team as well are kind of focusing on a lot of that intervention as well. But also, like I say, does kind of centered around education, further education, what we can do in terms of housing as well. That's another thing that we can, that I know Callum and the team are looking into as well. So it's a holistic approach. Obviously, this is just one step of that in terms of the BCS. But we think the BCS, and I've been clear with Anna and Callum as well, that also we need kind of, like you rightly say, KPIs and as well to prove that it's working. because we are spending a lot of money. We are spending £2.3 million, and we need to ensure that it does have an impact, especially those communities that need it the most. But I think this is a good direction, a good step forward, because people, like Sarah says, don't rightly trust the council in and of itself as an organisation to deliver these outcomes, obviously from our past history. But working with the community and working with organisations that are the community themselves, we think can break down some of those barriers, and obviously people are more willing to hear about either the people that they know, rather than perhaps someone coming in and basically lecturing on what they should know. And that doesn't really work. So this is a kind of a new intervention we're trying to do.
Yeah.
Also, I think it's working with the community rather than going to the community. We all hate that phrase, but I think that's the really important piece on this, is that, I mean, I get so I know your team's doing a really big deep dive on deprivation. I think all of this is just going to work together. And it is going to be targeted. It's not going to be just randomly spread around the BCS. And so I think we have to do something. And this is going to be, the monitoring is going to be key. We've made that very clear. So yeah.
Yeah, and just to build on those 2 points, so both on that broader inequality question and the process of quality assurance and bidding. So on that broader inequality point, as the councillors have highlighted, so the fairness aspect of the council plan is essentially driving all of these different aspects. And there's this work, and then a different part of my teams are producing an inequalities action plan, which will look at how we can address some of that broader inequality. So as Councillor Adams said, we're doing a deep dive into deprivation, specifically in Goldbourne as a starter, it being the most deprived ward in London, which is staying on this organisation, and the ability for us to understand both those causes, the drivers, and what we can do about it. And you rightly highlight income, employment, overcrowding, and health are the biggest drivers. So we very much see that work as hopefully them being able to sort of really set out our clear direction of travel that will make this feel less like a bit on the side rather than as part of something as a wider whole. In terms of the process and who might deliver some of this and the bidding process, I think that I think many of you have highlighted. I think the paper at the moment sets out an ambition about the approach that we want to take in terms of what we're trying to achieve and how we might do it. I think we should come back to the select committee perhaps in time when we've identified some of those specific areas, those lots where we might be, whether it be a geographical location or whether it might be a specific need that we're going to try and address for a specific ethnic group who needs that additional support and connection, so that you can see in a more granular detail how this would be applied and what difference we hope to be able to make in each of those areas over a 3-year period.
That would be really great.
And I think the timing of this is really important. We're seeing the NHS is going to have to make substantial cuts, 30 to 40%, and they've already cut most of their funding into the voluntary sector. So the timing of this is really good.
That's good. And Sam, any questions?
Yeah, Sarah, you mentioned earlier about, which I think is really important, about selecting the organisations that provide this support. I think all of us in our wards will have worked with organisations that we know are really, really on the ground and know the residents really well. I was just thinking about, take one example, food banks, for example. They have such an in-depth relationship with people they deliver to on a sort of daily basis. Just wondering if you could give some colour to what types of organisations might be partnered for this.
I can come to that.
Sure.
Yeah. Hi, my name is Muskan, and I also work in public health alongside Anna, and I am the head of health equity and engagement. Sorry for not introducing myself earlier. But our BCS, we have over 600 community groups and voluntary sector organizations in the polo. Some of them are larger anchor organizations which are well established and have like wider infrastructural capacities as well. And some of them are quite new. Some of them are not even entitled charitable status. They are CIC, or they are like small community groups which sort of also came during the time of the pandemic and have started to emerge as mutual aid groups as well. Some of them also sort of very much feeding into the food banks and into the wider clothing banks, etc. So our idea is to sort of, like Callum and Anna sort of mentioned earlier, this is a very place and people focused approach. We've got enormous amount of data. We've also got a lot of community insight to sort of understand which are the people and which are the places with the most to gain. And then we'll sort of identify those local small community groups and organizations who already deliver in those areas, who are based in those areas, but are also sort of have specific beneficiary groups. So for example, if you think about Al Hassaniya in the north of the borough, they have specific interventions laid out for the Moroccan community. Similarly, if we look at the south of the borough, we know that the Chelsea Theatre, the SMART organization sort of have dedicated function for individuals with complex mental health needs. So based on the kind of interventions that we are hoping to develop through the outcomes will be, so basically the market warming exercise will be for the entire sector. But then the bidding process, like you said, Councillor, would be to sort of have a very specific criteria around this is what we're looking for, and this is how we want to sort of allocate the money based on the organization size and the interventions we could deliver. We obviously want to provide an equal opportunity to all the VCS to apply rather than picking and saying that we want to work with you, because obviously that's not how we operate. But again, like the criteria will be highly dedicated based on which community groups we want to focus on, which health interventions we want to deliver, and which areas we think will have the most to gain from these community-based health interventions.
Quick question, page 23, 5.3, this 3-year program that introduced a novel approach to leverage, is not marketing for this one. It's very sophisticated paper, I think, for something that's novel. I was just wondering, background, is this done elsewhere in London or UK, or how much of it is coming from scratch? It's quite rare to find something when you're picking something up new and doing something novel.
So we have had a lot of conversations with other public health departments, looking through the evidence base of what's worked in other areas. The idea of kind of micro grants in the community aren't new. Some of you will be familiar with our Change Your Life programme, which is a very effective programme generating a community conversation around health issues for very small sums of money. Also, throughout the pandemic, you'll be aware that we got a significant amount of funding from DLUC, which was to have conversations with communities about vaccine hesitancy and to work with communities to improve uptake of vaccination. So those two projects particularly we've learned from and have fed into our thinking around this, plus conversations with other parts of the country who offered kind of similar grants programs where they've really looked to invest in the capacity and capability of the voluntary sector to train them up and to skill them to deliver health interventions in different ways. Another factor that really came into this is when we looked out to talk about recommissioning the Healthy Lifestyle Service, we looked at doing an umbrella contract working with local community organisations. And we didn't get community organisations coming through to operate as a part of that contract. One of the reasons being is they told us they didn't feel they had the skills or their capability and capacity to engage in that contract with us. This is one-off 3-year funding, and our ambition is that at the end of this process, if we go out to commission public health services again, and we have an umbrella component where we'd be looking for a big provider like Turning Point, but asking them to engage with our local voluntary sector to deliver with the services, we have built the capacity of the voluntary sector to start to respond in that way and be a part of our commissioning offers moving forward. So a lot of kind of background work, thinking about how we commission, thinking about who provides our services, the learning from the work we did during the pandemic, and looking at the evidence base has kind of led us towards this approach. But we do think there are novel elements to what we're doing, and we're really keen, we're really excited about this, and we really think it will make a difference.
And the only thing I'd add to that is our learning from Grenfell shows that the more you can understand the community you're serving, the more you get to know who they are and what they need, and you recognise that they might need something different from other people, the more you're able to provide a targeted intervention that works. So this is a movement from the council to try and understand our residents more, to deliver better services that make a difference to them. So it is new, but it's based on some of our learning over the last 6 months.
Thank you. Do you mind if I quickly ask?
Yes,
and I'll come to you.
Yeah.
I was just gonna, this is just me understanding it, as in all our papers, it comes up in terms of inequalities in health in this borough, but just what is just to hear from you what you think really needs to be addressed to shift the fact that we have some of the highest life expectancies. Fourth for women in the country, but then we have the highest, like fourth highest life expectancy gap. I've heard what councillors have said today, and I just want to really understand what you think is going wrong there, because this is obviously going to play a huge part into helping that. But I would really like to hear about that. And then also, again, with and I know this plays so much into health as well. Not necessarily the council always, but what and again, this is going to support this, but with cancer screenings, why do we have some of the lowest in the country there, and what is going wrong? Because it is very concerning to read, and I know this is going to hopefully start doing really amazing work in this area, but it'd be good to understand it and why you think it's happening.
So a couple of elements to that. So one, as councillors have said, the causes of inequalities are broad and they are multiple. And once we understand that and understand that causes are at the place level, they're at the community level, and they're at individual level, then we know that the interventions that we need to put in place need to be at those three levels as well. And ideally, we're rallying all those interventions at the same time to have an impact. So to give an example, colleagues have spoken about employment and housing. So we know their challenges. So we invest as a public health function in the organisation within those services to make a difference, to work with colleagues to stimulate the economy as well, to look at creating jobs, good work, good employment for people. And alongside that, we know if we increase income, we increase people's choices and we increase their health and well-being. So our approach as a public health department and as a council is very much to work in that way. So, and it is only by working in that way that we will have that impact. And that's what I set out in my very first annual public health report for this council. What is our kind of cross-council way of working together that will impact on health inequalities? This initiative is very much focused at improving the reach of those services to the people who've got the greatest capacity to gain from these interventions. So as well as potentially the very much public health services that I really want to target at people. So I want to make sure the right people are going through our smoking services, to our weight management services, to our actual exercise referral schemes, to our alcohol and substance misuse services. At the same time, we also want to reach people around the employment opportunities, around their housing opportunities, around the education opportunities, and create those pathways back into council services and wider opportunities for people. So this initiative gives us that opportunity around reach, but it fits in the cradle of that wider work that we're doing across the council and across partners.
Okay. And you think, not sorry, to go back to screenings in terms of cancer, but you think that type of work is going to be more likely for someone to. So, and I understand from what Caution particularly said that a huge amount of this revolves around trust, but.
So cancers, I think it's a very complex area, as colleagues will know. I think there are particular, challenges around reaching out to community groups, getting messages out to people around cancers, getting messages around services, access to those services, and making people feel comfortable and confident to access those services.
And about people being seen and feeling like they're seen and feeling like they're being heard and they matter. And I don't think it's a coincidence that some of the biggest health inequalities align with our social housing, where that's located. And, the history of this organisation and the history of people's experience, again, I don't think it's a surprise that people aren't necessarily trusting, don't necessarily feel the system is there. And I think that what I'm interested in doing in terms of bringing the communities department along with this journey is to try and change that narrative and to try and enable us to reach out to people in a different way.
And in terms of cancers, if I may, there's also, in addition to the trust, there's also a very huge cultural factor.
Yeah.
So Kensington and Chelsea has a very diverse population, and particularly when you think about from Middle East and Moroccan areas, Moroccan speaking and Arabic speaking populations. When we think about cervical screening or breast screening, there's a huge amount of stigma that is attached to it.
Yeah.
And we also understand that it comes from a very deeply enrooted cultural understanding of, how can I have somebody else screening me in my, private areas to sort of really get the right results. And that is why these interventions will bring more culturally sensitive messages and awareness around such screenings back into the community rather than someone with NHS or local authority Lamia speaking to them about why they need to get screening every 5 years, etc. So we're coming with a wealth of community insight and knowledge, and we know that what the barriers might be to not just access but also availability of services. And through this, we'll have the opportunity to ensure that both of these areas are addressed and we have widely embedded on.
Or should you want to ask the question?
Yes. I'm very curious, this is a very interesting piece of work, very important because it deals with people health and well-being. But my curiosity is, these CIC, how accountable they are? How accountable is the CIC, Community Interest Corporation? How accountable are they to our residents and to us? That's number one. And two, how are we going to get, because engagement is a very difficult thing for some people, not all. People skill, you cannot buy it. How are we going to reach the quiet voices, those who are not engaged, that are in real need for support?
That's a very good question, and thank you. And we are very aware of the quality assurances of the small CIC and self-generated groups as well. And obviously, we want to sort of support them in delivering those messages and creating that momentum and really socialize the ideas of public health interventions. However, before funding them, we would be sort of encouraging the established charities to work in partnerships with them. So we are sort of really hoping that the collaborations and profit partnerships will form as part of the Healthy Communities Network. That is one of the prongs of this wider approach as well. So the network is open to all, the training is open to all, but the enhanced training offer will be to those organizations which also receive the funds. So we're not leaving anybody behind. We are providing the wider opportunity to everyone to come together and, benefit from those learning spaces, but also sort of receive that wider infrastructural support should they wish to then again become charitable institution as well, or like partner up with some other organizations. That's our approach.
Thank you.
Thank you very much, and thank you for all your time. I think it's a really important report and very welcome it. I hope everyone gets to look at it. And I think it'd be great if we could see it when it's in its later stages. If it came back to committee, that'd be great. Thank you very much.
And thank you for letting us bring it tonight, because that's really important that Susan and I before.
No, I think it's really, really interesting, and I'm glad we spent some time on it. Oh. Yes. Families just remind me that we need to support the recommendation 2.11. We don't need to, but we will. 2.11 of the key decision and whether they would like to make any recommendations to the leadership team for its meetings.
It's in the supplementary.
Yes. This one. Okay, let's go. Yours. 1 second.
Excuse me.
Okay, sorry. Do you want me to read them out?
I don't have that supplementary.
Is this page?
Yeah.
This one. Yeah. So it's to endorse the proposal for a voluntary and community sector development investment program and its delegate responsibility for distributing the grants. The director of public health quality in consultation with the director.
Can I just add that Josh and I will be cited on any organisations that are put forward before it's agreed.
So 2.11.
Oh, another question. How long will this take? for me to see some results.
Oh. Thank you, Portia. Bye.
We'll get, I mean, it's up to the committee. Committee can call it back in and so they're like,
Yeah.
to review it.
We'll get an update from, moving on to agenda item 5, the Learning Disability Plan 2023 to 2026. This report provides an update to the Select Committee on the development of the Council's Learning Disability Plan 2023 to 2026. Beth Mills, Director of Learning Disabilities at Complaint Services, is to present a report with Josh Randall. And we're also delighted to have Sue Griffin here. Thank you.
Thank you, Chair, and thank you to and Seth for coming this evening. So yes, this is our learning disabilities plan from 23 to 26. This builds on the big plan that was launched in previous years and is a refreshed learning disability plan going forward. So how can we as a council ensure that those with learning disabilities can lead the best lives they possibly can with support they need, either from ourselves, family, friends, and other parts of the community as well. And also considers what must be done to meet our duties as a council at the same time. What is known about the needs and wishes of people with learning disabilities and how we can help them as much as possible. And Seth and obviously Sue can speak to that in a bit more personal detail, but happy for the committee to ask any questions for us on the new plan.
Do you want to add anything now, or we can start with questions?
I think I've been thinking about this really, well, quite a lot, to be quite honest with you. I don't know whether you guys know me, you might have heard of me being a bit of a nightmare. My name is Sue Redmond. I'm joint chair of Full of Life. I'm also the parent of a 32-year-old young lady with complex learning disabilities and drug-resistant epilepsy. And I think that what we've all missed, including myself, is that parents who have a disabled child will be lifelong carers. I think when it comes to carers groups, we're not really seen because we're seen, but we're not seen. And I think that's something that I think this will help to change. But also the other thing I was thinking about was in terms of money, because everybody talks about money when it comes to our sons and daughters. And I think nobody realizes that they actually do contribute into the communities big time. So I've gotten some figures here that just for us as an organisation, for the one-to-one support workers and for the staff that we employ via Full of Life, for instance, for 2022-23, £164,000 went back to the HMRC because of the services we provide to our families. Staff take-home pay from Full of Life for 22-23 was £541,000. That all goes straight back into the communities and into their lives. And Full of Life's contribution to staff pensions for 22-23 were £13,000. So when people see our sons and daughters, and whether it's from health or social care, they see how much they're going to cost. But they don't see how much they actually contribute back into the communities. And they don't see either how we build communities. They don't see how much parent carers give for the whole of their lives. They don't see the impact it has in terms of caring for someone with complex needs and challenging behaviour has on parent health and well-being. And, you know, we did some research a few years ago into the health and well-being of parent carers. And on average at that time, we were getting something like 4.5 hours sleep a night. And if I pull that all together in a job description to employ someone to do it, I would be breaking every single employment law under the sun. So I think when this comes to you as a table, actually there's far more to our families than people realise, including myself realised at the time. So yeah, I just thought it would be interesting to people talk about money, but they don't talk about the actual impact and the value of what comes back in because of our kids.
Thank you, Sue, for that. And I would also like to add, Chair, that as part of the Learning Disabilities Plan, so we have 7 key priorities. One of the key priorities is carers, housing, independent living, and health, co-production, information and advice, and preparing for adulthood. Now, as Sue mentioned, the work Full of Life does is one of the organisations in the borough.
they support 174 carers. So the golden thread in this plan is to pull all that work together, and then going forward to also see how we work together in various work streams to deliver on this plan. So it's a very much a combined effort. So I'll be happy to take any questions.
Thank you very much, and thank you, Sue, for coming and talking to us. Really important your way. I have questions, but I'm going to start with my colleagues first. Stuart.
Thank you. Really, really easy to understand and great report. Page 13 of the supplementary pack, you mentioned about sort of the importance of focus groups that have been set up in order to just make sure that this people on the ground are actually receiving the support that they need, and more importantly, I guess, able to feed into the wider discussion about whether things are working. What feedback do you get from those on whether that's a valuable process for them, and they can see things improving as a result of their feedback? Is it what all well and good them taking part, but actually if they can't see a change, I mean, sometimes there doesn't need to be a change, I guess, but to what extent is that a success in their?
Yeah, and I think that's the importance of having that feedback loop. So the focus group as a partnership really is about a multi-agency group. So it's co-chaired by Sue and myself. It includes residents, including those with experts by experience, and also parent carers, people from the education departments, health, etc. So it's really the whole system that comes together to talk about the progress they're making in whatever specific areas they're covering, or the challenges. I think the important part about it is that we get a strategic discussion as well as actions around what we need to do to improve things. So I think, speaking from my side as local authority, it's an opportunity for us to really discuss really difficult issues, hold each other to account, and then try to progress the matter and take actions forward.
That's right. I mean, we've been involved in a lot of things, and Seth came at a time when I have to say I wasn't very happy. And the red mist had descended quite a lot. And so when you look at trying to map progress, sometimes in this work you fall down rabbit holes. You think you've got one thing and actually then you discover something else. But actually, if you're not mapping it and tracking this, then you're not going to be able to see the difference that people are making, that things are making. You're not going to be able to map where things are getting difficult and evidence that back to people. Because for me and for anyone that's involved in Full of Life, unless we start to see a change, we won't get involved. It's as simple as that. And that's what this document is about, is making sure that actually changes do happen and that paper doesn't refuse ink for another 25 years. That's what it's about. And I've done a lot of staring. Seth has been kind of you know, sort of on the receiving end of like, we're not doing this again. And this is where this has resulted from, because we need to see change. You know, I want to be able to have threatened to haunt people a lot. I want to be able to know that the system is there to care for my child when I'm not there. And that's my ultimate aim, is to know that that's embedded, that good practice is there.
If I just jumped in one final point from me. You also reference the importance of employment in the sort of ecosystem of making sure that people are supported. It strikes me as that not only does employment sort of increase individuals' self-worth in the community, but also has the benefits you were discussing earlier about giving back in terms of revenues and all those monetary. And also, I guess, really improves people's skills to kind of decrease the reliance on service use in the future. Perhaps how do you go about engaging employers in that process? Because it strikes me as that's the difficult bit, really. Or maybe it's not difficult, but sort of how receptive are they to supporting?
So it's work in progress. We do commission an organisation called Balance that does specific work with organisations in the local area, but also works with residents to train them up, you know, help them write their CVs, help them train and get the skills so they can get into employment and stay in employment. So that's one of the big successes is paid employment, but sustained paid employment. But we do recognise, as well as that we've done locally, I think we're over 10%, which is double the London and the national average. There's still quite a lot more to do. We want to encourage more businesses to be more inclusive and disability friendly. So that's an ongoing piece of work. And again, this plan helps to kind of map out how we do that collectively.
I think also, you know, again, it's another thing that, you know, it's for people that can be, you know, employed, absolutely fine, you know, get out there. If I would say if the borough is commissioning out anything, whatever the service it might be, how are they evidencing that they're outreaching to people with learning disability? Evidence that in the reports coming back. If we've got to have a totally inclusive society, that should be there. But I also think too is that you're looking, you know, people like my daughter, because and the young people and the people we care for at Full of Life who've got very complex needs, who will never be able to be in paid employment. But actually, and that's the reality of it. But how are we thinking about them? Because before you know it, you know, there was an agenda quite a few years ago. It was like we've got community-based services, but basically that meant people were wandering around the streets pretending they were in the community, when actually our sons and daughters need a meaningful day with staff that are really well trained to understand their needs, so that you actually prevent them being, you know, the people we have Full of Life are bordering on amber and red, being admitted to treatment and assessment units. And I know if that was my daughter, she would never get out of there. So you have some psychiatrist with a load of drugs, basically, as far as I'm concerned, and that's not good enough. So if we as an organisation are able to run a service like that for people with that level of need, they still too, they go off the agenda, basically. And they disappear if you don't, if we're not questioning and pushing that, and pushing the levels of need and the training that the staff need to have that. And, you know, we do that at Full of Life. It's run by a bunch of mummies. I don't see why other people can't do it. But I think we must not forget, because they have been forgotten, not just here, but nationally. People with very complex needs have been forgotten about. And I think that's something that should be embedded all the way through. And it is in here all the way through, because otherwise, you know, they get lost in the system, that, you know, they disappear from the community. And my daughter has a right to be here because she's contributed to that, as has all the other kids.
Thank you. And I just want to say how lucky we are to have you involved in all of this, even if it involves you sort of staring at what we've done. I just wanted to start by sort of, I guess, sort of, it probably plays into preparing for adulthood, but also housing. And this is probably, I don't know who this goes to, but just to sort of prepare for sort of independent living and what you speak about in here with the current shortage in homes that we're experiencing in London and generally in RBKC. Are we sort of optimistic that we can deliver on what is needed?
It's a really good question. And I've got to say that Sue has been absolutely amazing at advocating for this, and better and better living conditions, homes for people with learning disabilities, so they can be a part of the community as much as everyone else. And I think Seth is, and all the other team here has been very annoyed about me going on about this, but one of the priorities that I want this portfolio to achieve is better and more housing for people with learning disabilities. And what we're doing right now is in Portsmouth Ward of St Helens, looking at properties that we can look at to refurbish. So, for example, St Helens Gardens is one that we are seriously looking at and hopefully be able to get over the line for people with learning disabilities. And that is going to be, you know, a starting point of eight flats in order to store that our people with learning disabilities that aren't perhaps based out of borough, just due to costs, etc., can come back home to their own communities and do that as well. And looking at different situations like Piper House as well, which is not entirely appropriate. Again, that's in Kensington as well. I think it perhaps in your ward, you know, ensuring that those people get the best living conditions they can as well, because as Sue absolutely advocates for, we need to ensure that that people can have as much independence as they can have as well, but also be as part of the community as much as they as well. And I must say, I think this council has not done a very good job in the past, and Sue was very critical of that, and rightly so. But that's something we want to correct, because we've had such fantastic investment, for example, in our education facilities. We've got the best schools in the country and the best immunities for them, but perhaps not for people with learning disabilities or in adult social care as well. And that's something that I'm determined to change again with Sue's application of that, and with Seth's help, who's doing a great job so I'm improving that. So it's a really good point, Chair, that you raised, because it's one that is really important and one that we need to correct.
Yeah, and just quickly to add to that, in the report, it says we will deliver 5 accessible units a year for adults with learning disabilities. I just wanted to make clear, is that 5 per year, or, I mean, I don't know how many we actually have in total at the moment. I just wanted to clear that up to understand.
So that's a commitment from our general needs housing colleagues. So
Yeah.
the idea would be they will ring fence their stock each year for the allocation,
Okay.
and they'll be put forward for residents who learn disabilities
Mhm.
to have a first access to it, to make sure it's appropriate for them so they can utilise. That's a commitment from our housing.
So it would be 5 ring fence
Yes.
per year.
Yeah, in addition to the St Helens Gardens as well, etc.
And do we have a lot of people placed outside of our at the moment?
We do, yes, that's it, 78 and 47 residential care, so.
Yeah, it's surprisingly more expensive to have people outside of the borough. We've got some people as far as Scotland, for example, but then to our residents.
Yeah.
Obviously, that's a cost to the council. But having people locally based obviously is better for them, better for their families, but also it's cheaper for the council to provide as well.
Thank you for this well-detailed report. Page 37, 5.11. I know this job can be a bit daunting and overwhelming, caring for a family member, but it's also rewarding.
Yes.
And I would just like to know what supports are in place for our carers, people who care for their loved ones. And I would like to hear that in practice. I mean, what would that look like in practice? I mean, I've seen the list here, identification, recognition, appreciation. What would that look like in practice? How would you support someone that is supporting a family member? That's number one.
Yeah.
And 2, this is on the health and priorities on the change book. What are we doing to improve the intake of health checks in people with learning disabilities? These are my 2 questions.
Thank you for the question. So the first one around carers. So it's a statutory responsibility for local authority to provide an assessment and identify carers' needs just as much as the residents' needs, service users' needs. And that process simply is around the opportunity to give the person a chance to talk about the work they're doing, the support they're providing, and then identify what kind of support would improve things for them, as well as help them in their caring role. That could be a combination of things such as short breaks, having time away from the caring role, whether it's to go and take time for themselves, go and take time to do other things for them, for themselves or someone else. Also can be provided services, so they can have direct payments to arrange things for themselves that can either, again, make things easier for themselves or provide support to themselves. Because sometimes carers have needs themselves, they might have their own disability or complex needs. There's also scheduled respite, so as people can have time away from the family home to go into residential respite for a number of days at a time to give again the carer time to just recover, rest, or spend time with other, families and friends. So there's quite a range of different services that the local authority offer, but the starting point is identifying the carer's needs and what's important for the carer to make sure they feel supported in their care role, because it's a very, as you said, it's a lifelong role. It's ongoing, it has lots of different demands, and sometimes you're caring for multiple people as well.
And how often is that reviewed?
So minimums annually. So it can be as often as monthly, but it's minimum annually.
Okay.
And also, just so you know too, that Full of Life have a family support service. So when a child is diagnosed initially, the clinicians at St Mary's and Chelsea Westminster have our details on that letter. And it might take families a little bit of time to come to us, if you like, because you're still processing where your head is, basically. And then we basically deliver the information, advice and support service. So anything to do with special educational needs, we do that too. And then we saw the gap in service and in sort of independent support for parent carers when children were transitioning from children into adult services. So we have a carers advocacy service under our umbrella as well, helping people, understand the system. We provide legal training. We're very good friends with Professor Lee Clemens from Leeds University in terms of the legal rights and stuff. And if parents have got any issues with services or whatever, they can come to us for independent support. So that's under that umbrella. So technically, once you're on our loop, if you like, then you can get that support via us, including benefits and all that sort of stuff. Making sure you're not falling through the gap. But it is a lifelong role, and it has it can have a huge impact on us as parents. And I think, for me, the housing stuff is the next step. It's important that you know that your child is happy living somewhere and they can still see you. You still have that connection. You've not disappeared. I do not want to see parents die and then the child, they're no longer a child, but it's their child, is then housed outside of the borough. That's not, so they lose their parents and they lose their community. And that should not happen here. We're a wealthy borough, no matter what anyone says to me. I don't believe that we're not a wealthy borough. It depends on whose hands the money is in. And I know that because between 89 pence and 92 pence in every pound that comes into Full of Life goes to direct support for families. So when people tell me there's no money, I don't believe it. And when people tell me they've got no land, Earl's Court has been flattened, I live down the road from it, why is there nothing put into those schemes for our families? And the same with Ballymore at Gladbrook Grove. There's opportunities there. So Seth knows a bit of a standing joke. I'm looking over fences to see where there's land, because why not? We can be creative and innovative, and we should be.
Thank you for that. How are we gonna improve the uptake?
Yeah. So one of the things that's important about the plan is that we want to make it a live plan, an active plan. So this plan, it sets out the 7 priorities, but underneath them, they'll have work streams. So each part of the plan will have a work stream which the lead department, so in particular, that's health. So lead clinicians and lead ICB leads will be part of the work stream. We know any health checks, the uptake is not very good. The information and advice that's given to families is not very strong, but also the reasonable adjustments that sometimes required to allow people with complex needs to come into the environment, like the surgery, have the annual health checks, again, needs improving. So those improvement plans and action plans will be part of the work stream. And as Sue mentioned as well, so that work stream will be something of an ongoing piece of work that will work towards improving those figures, those statistics, so there's more uptake and obviously people get better health checks throughout the year.
And parents will be involved in all of those work streams. So it's families working together with everybody on those work streams. So some people will be more passionate about health because that's where their son or daughter is right now. There'll be more about housing. So people will be heavily involved in and mapping that change. And again, when it comes to the health check side of stuff, my daughter's had her annual health check, that's fine. But then I'm looking at, okay, if something happens to me, where is her information that people can access easily? Because they should be able to access, crisis information. And I've now discovered there's something called sorry, my chemo brain is gone again, emergency care plan that the GPs actually have for palliative care. But actually that can also be used for people with learning disabilities. And so I've managed to get Tessa's information put up onto one of those plans. And I now want to look at that so that if an emergency did happen and emergency planning was needed, the ambulance crew can have that information coming to wherever Tess would be. And that if I'm able to do that for Tess, then there's no reason why that couldn't be rolled out for other people with a learning disability. So,
And in addition to that as well, there is an important aspect to that, where there's the health passports as well, which is something that's really good practice for people's information to be available to any clinician that's supporting a person with complex needs, so they can see the needs, the things that they don't like, so things that would maybe discourage them from accessing the service, if it's needle phobia or a range of other things. And that's very helpful for a doctor who's going to support somebody who may not be familiar with them.
Yeah.
So again, some of that work stream will be encouraging the uptake of that and the production of it, so should I say the implementation of that. And in addition as well, we have things like a dynamic support register, which is very important for those with extremely complex needs because it's very preventative. It's those who are at the cusp of crisis. Again, the dynamic support register is something that's maintained by the local GPs and ICB, but it allows them to track and map people. So when things are becoming very difficult for them, the professionals of social care and families can refer into them and they can do that preventative work again to stop them having to go into hospital. But that will all be part of the Safe Health workshop to again make sure these things are improved and available to everyone.
Thank you.
Thank you. Thanks very much. This is really amazing piece of work. It's great to have you here. I think your daughter's extremely fortunate to have such a powerful advocate. Believe me, she's a ginger ninja and she's got a very good right hook. So I'm a mere mortal. The question I had was a really general one about data and how confident we are in the information that we have around uptake. And because there's quite a lot of support that is available. And do we know what the rates of uptake is? So does everyone, what rates of the health checks, what rates for the education and healthcare plans for the under 25s, accessing that, the communicate all of these things that you've mentioned. Is there data that we have around what proportion of those service users who could be accessing it that are being missed at the moment, or that aren't accessing, that there isn't an uptake for it? And are they like specific of a specific demographic or background or ethnicity that we might be not reaching? And what can be done to? I don't think we're hidden. I think we're very obvious. I think, from when my child was 2, she was diagnosed. And so everybody knows about her once you've had that diagnosis, and then it's school and all the rest of it. People know where people are in general, I think. Well, I could say 99.9% of people know where people are. The issue would be whether you can, say for health checks, sometimes people are so anxious because stuff has been done to them in the past where, I don't know, needle phobia, they've been hurt. So how then do you work with that to basically desensitize people, to lessen that anxiety and to stop that sort of thing happening so that bloods can be done? My daughter was one of those. She was tactile defensive. And now she's no problem putting her arm out because I've got staff that will work with her and will do those pieces of work with her. And it comes back to that whole other side of this, is that how are we developing and training staff to work with this particular group of people? It's not just going in and bathing somebody and, putting the paper. This is a very complex people and can be very complex people. So you need really, really good, well-trained people that are well paid and want to stay in the job, which is the other thing. And I think, going back to your mapping and stuff, I think the numbers are there, but it's then how do you work getting people in there? St. Charles Centre, the dental service at St. Charles is unbelievable for people like my daughter. They are absolutely fantastic. And at one point she didn't want me there, but she would go with the staff. And she came out and I was told that she'd had 2 fillings. And I thought, I don't believe this, that actually the dentist was at risk of wearing his drill. But no, it didn't. It worked really well. But, people are well known because the transition from children to adult services happen. They're mapped. So that transition time happens into learning disability services or into continuing healthcare services. And they're known. My issue will be is that where's the planning ahead for when we're no longer there? Where's the planning ahead in terms of the training of the staff that are going to be working directly with people with a learning disability? And where's the planning ahead in terms of employment, like you were saying, for people that can be in paid employment? When you see the internships that happen at here in the council is great, that happen at Chelsea Westminster, you see people there and they're getting the right support and they're actually, really proud of themselves. And that's a fantastic thing to see, but also for society to see that is wonderful, and I think, we need to build on the blocks that are there now and evidence it, big time evidence it.
Just to add as well, so the data from the NHS provide around the animal health checks, and we know that there are about 679 people registered with GPs who have a learning disability. As Sue said, so we know who's registered, but how many people are getting their animal health checks is the issue. So the NHS have a KPI. They do report to
Yeah.
us around the KPI at the focus groups. So we do get that presentation and data. KPIs are around improving that uptake. So again, as part of the strategy, I think have to work with them towards.
Sam, do you have any questions? I think my last question my last question was just going to be around, is there a sort of one-stop shop for the carer or the individual in terms of how they know how they can access the events you speak about in terms of disability friendly events and venues, so that that service is sort of streamlined and easily accessible to everyone?
Any information at all about any of this goes out to all families on our database. So Two Little Family Services will send us information. We send it out to anyone in our database. They also send it out to people on their database. So there's a kind of a two-pronged attack, if you like, for want of a better word. But also the issue may be too, because I'm as guilty as anybody else, is that people will get the information and think, yes, okay, that's great, and then park it. Because then you're too busy doing something else around them. So if we know it's there, but whether people will read it is another thing. But, you know, we just have to keep plugging away at it.
Okay. Thank you very, very much for coming and for this report. And soon for your contribution to all of it, and Seth and Josh in particular, great.
Yes.
I'm sure you're very happy to hear that he's committed to,
Yes.
in terms of producing this.
Long process, I think we're getting.
Long process, but it.
Oh, we'll get there quicker than
Yes.
things.
Thank you very, very much. Thank you. Moving on to agenda item 6, the Carer Strategy 2023 to 2028. The purpose of this report is to update the select committee on the development of the Carer Strategy. Gareth Wall, Director of Integrated Commissioning, is to present the reports with Dr. Reynolds. We also are delighted to be joined by Brian Jones, who is Chief Executive of the Carers San Francisco. Earlier this week. Do you want to start?
Thank you. Yeah, thank you. So this is our carer strategy, obviously, which is extremely important. And this is for adults who provide care in the community, like we said before, Sue, but for free, basically. And you know, it's up to trust, try and find out who carers are, how we can obviously support them, obviously through the strategy and the advice and services that are available to them as well. So the strategy has been co-designed, obviously with ourselves, Brian and his team, and other user services as well, and working closely with other groups and organisations, etc. We also collaborated with others such as the ICB, NHS trusts, and all that type of stuff as well. And what we want to do, what the ambition of the strategy is to identify early and recognise experts by experience, so that people who can, you know, come in, help. You know, have some experience in the past, especially people coming up. Obviously, ensure that they are valued for the role that they play, because you know these people have, you know, sacrificed so much of their personal lives to look after a loved one or another family member. As I said, without pay, and trying to do that obviously is a great thing that they've done, but it's also had an impact as well on the kind of thing. And what the strategy trying to do is trying to inform people about the support available to them as well, because you know it can be quite a intense time looking after someone, especially as a carer, especially for full time, and especially the challenge that brings, especially like loss of employment and all that kind of stuff as well, and also how we can support them in balancing their caring versus their personal lives as well. So that's what the strategy comes to do. Having Gareth and Brian here to answer like more specific questions, especially on the ground, and how it can go and how do that. But we'll obviously welcome your comments and views on how we can about this.
Josh has said that first.
And Brian, do you want to do anything now, or you can wait till questions?
No.
Thank you very much, and thank you very much for this report. Really welcome it, and it is a great report. And I know that we are very much leading the way in terms of this in the country. I've been told, which is great. I think where I would like to start, sorry, actually someone else jump in first and I'll get to where question wise I want to start.
Thank you for coming this evening. But In 5.2 in the main report, you go into some detail through the carers network about how carers are sort of in one-to-one sessions, or they can submit any concerns in writing, etc. Just trying to understand how vital you think that is in terms of the ability to engage carers in the process and making sure that they're being listened to. I think personally, I would have thought that actually a lot would be reluctant to voice major concerns in a group setting for many different reasons, but just want to get your thoughts on how important the one-to-one is.
Just as a start, the point in 5.2 was specifically about the creating access for carers to be able to contribute to the development of the strategy.
Yeah,
the carers network, you work with us in all sorts of ways, but in developing the strategy, kind of helps to put better settings in place for people to feel comfortable to contribute their thoughts and ideas. But as you say, kind of beyond that, that's kind of bread and butter of what the carers network does generally in terms of creating those different channels for people to come forward to as well.
And so I don't think there was any hesitancy on people's views to come forward, that they're quite vocal in their thoughts. We operate a number of carers forums where people can contribute and talk about issues. So I don't think they're not a cohort, and I'm carrying themselves. We're not a cohort that's quiet.
Also a couple of questions. I just want to understand what support is offered financially for carers. I know it says in the report carers can receive £76.75 as per the National Weekly Benefit. I was just wondering if there is additional funding as well as that can be applied for individuals. And it just concerned me in terms of particularly the cost of living crisis. If a lot of people are most likely continuing to work, and in terms of what a sort of educational campaign around workplaces in being much more lenient and understanding with employees who might have those demands of being a carer as well, and what the eligibility is for these benefits.
I can start. So the weekly allowance of £73 means tested, and it's applicable only to certain people. So if you work full time, you're not eligible for that amount. Leading on from what our colleague said, and just to set the context, what Carers Network provides is that assessment. We carry out that assessment, we understand people's needs, and we'll then signpost them accordingly. So we carry out that sort of street function of the local authority. People can apply for a grant from the local authority, but it's only annual. It has to be every 12 months. Not every local authority, certainly the local authority I live in, we don't have that one, and it doesn't exist. And certainly in the cost of living crisis, we work with lots of partner organisations. So we can refer to free firms, we can refer to various charitable trusts across the borough that can help with purchasing a fridge, washing machine, whatever the need may be, over and above what they need that from.
So, Karen, do you have an idea, hopefully, of the answer to how much from local government carers LBKC could be receiving yearly? What Brian just spoke about.
It differs. There's not a single answer.
Yeah.
It very much depends on somebody's individual assessed needs. There's a kind of a base on that comes from Department of Work and Pensions as the carers allowance. But as Brian says, there's a grant available, but somebody's assessed needs, and particularly if their assessed needs and the needs of the person they're caring for are particularly high, that we can make available. So it's not there's a range, not really that's kind of a simple figure. And also part of as Brian said, part of the role that the Carers Network does so well, but also some of the other organisations that have been part of their remit for our contract with them support carers where they might know a particular community particularly well and have that kind of really is around income maximisation. So making sure that all of the routes, whether through Department of pensions, the local authority, NHS routes, charitable opportunities are maximised as much as possible. On your question about eligibility, Brian's already covered some of the one of the things that is kind of quite usefully set out in the draft strategy as it's behind the report, is that it's relatively open. And so of the people that come forward to local authority service for assessment, and are assessed, 88% of them are deemed eligible. And some of the criteria which are set out on page 52 of the agenda, it's expressed as when somebody isn't able to do something. Where if somebody isn't able to do something practical like shopping, cleaning and laundry, watching over someone if they can't be left alone, that's a criteria for somebody then being eligible for this support. So it's actually quite an open process for people to come involved in. And then once people come through the door, that's when there's the opportunity for organisations like Carers Networks and others to look at other ways to maximise that.
Yeah, and just on, I mean, if we separate it away from financials, but what we are doing to educate businesses and employees of people who might have rising demand for time also being a carer.
I think that's a really good point. I mean, as an organisation, the council is very good, and it can be organisations like ours, and lots of them in Bath do have a good track record. One of the things that I think is an ambition for this strategy to achieve is for us to understand the current picture of that better, and to kind of find ways to improve it where there are gaps. This is a strategy that sets out ambitions over the next 5 years.
Yeah.
I think one of the findings of this piece of work is there's some good examples of that around, but we don't know enough about it yet. And this also sets us a platform to think about how we can best get that across to different types of organisations, because it'll be more convincing in different ways to how you've talked.
Yeah. And I know Brian spoke earlier this week of your 2 care weeks in the year. Those are your campaigns that you focus on.
Yeah, so for us in particular, we're not a policy-driven organisation. That's not our role. We are a service delivery partner, but we do work with a number of really large organisations based locally. We're quite fortunate in where we are, and we're often approached to talk to companies about their responsibilities to staff. So we talk to them about what a carer may need as an employee, what that may look like, what a caring role may look like, and we do that through the staff forums. So there may be, we've had one where there was 3,000 people on the call. So it's, there are different opportunities to do that.
Yeah. Thank you.
Yeah, no, it was just a quick question about the specific interventions that might be available to support carers in terms of their own well-being and their own physical health and the emotional well-being, and also what additional, just in that interface with the local authority, what you think in your perspective could be done better.
So I'm not saying it's just Miss Guarantee or basically we have a great relationship with the commissioners. I come from a background where that's not always the case. I was a chief executive in the NHS Trust before my caring role, so I understand commissioners and closely with them. I think, but for us, we provide a range of support services over and above that commission service, a statutory function that we provide. So it could be anything from yoga classes, guitar classes, a whole range and a whole menu of different options that we can offer. For some people, it may be applicable. Others might just want that annual assessment, and we may never hear from them from one year to the next. In my own case as a carer, there's lots of opportunities out there, but I'm not the sort of person that go to a coffee morning or go to a knitting class, so it's not applicable to me, but we offer those opportunities to people.
And in terms of the sort of the feedback that you receive from carers in their experience, with their interface and with the local authority and their ability to access services, sort of what they might say about that could be improved, or
I think that a long time ago, and I've been in the system, local government system for a long time. not necessarily local government, but certainly with health, it's about telling that story once only, and trying to navigate systems can be complex at times. You know, who you contact a social worker, or do you contact somebody at health? There's a frustration there often because having to repeat their issues.
Thank you.
Just to supplement that, just to point around the numbers, and there's some data on what we know, which isn't as much as we'd like to. But I think it's indicative about some of the level come forward. We're reporting here that there are 970 people on our books in adult social care kind of next carers. But looking at the census data, which does also include young carers, there's an estimate that number is closer to 9,000, north of 9,000. There's an awful lot of people who identify themselves as being caring roles through a census return, but aren't known to our services necessarily, and aren't assessed in that way. So there's lots for us to do, and the ambition is there to do that. We also know that there are some people who, and we've heard this through the criminal research with strategy, some people who don't recognise themselves as carers, even though we would think of themselves that way. And some people who would almost find the category carer offensive because it's part of what they do. And so there will always be some communities, some groups, some families where that's going to be harder, but for us to find the right offer that might make somebody want to kind of come through.
So did you say, so of the 900 who are identified as carers and have gone through the carers assessment process, but actually it's 9,000 that
As
actually
an
are in a
extrapolated
caring role?
estimate from the
Wow.
Yes.
population, because that's what the census tells us is the number of people identified as carers here.
From
And
the,
yeah,
sorry,
sorry,
from
go
the
on.
age of 5 years old, which
Yeah.
I found very confusing.
Yes. But so that census figure includes all carers, whereas this is specifically planned adult care. But that's not going to, there's still like a huge number
Yeah.
that aren't on that books.
Slightly linking that, thank you very much. Thinking what Brian was saying from different angles. I realise now that I was a carer for several years, and it wasn't in this local authority, the person, the apprenticeship who I was looking after, and looking at priority to information and advice. I think you were probably saying exactly your experience was my experience, was the hardest possible thing was if you thought you had found someone who could give you some information, a week later they had disappeared and no one knew anything about what had been said to me by the last person. Their files, nothing existed at all. And relating it to Gareth's point, if the information and advice being given out was better documented, you might then be able to trace that back to say, well, how many people are we actually giving that to, and therefore advise that down, and therefore noting them down as carers, because no one probably ever sort of noticed me as a carer. So I think your 2 points link together quite well. And the question being, one, is that right? Is it common my experience? And secondly, is it regarded, that particular issue and the numbers of people, as something that can fit into priority 2?
So as a service, when we carry out an assessment or we have some kind of interaction with people, it is recorded on the system. Future reference. I can't, and Gareth can talk about local authority, but certainly from our perspective, once you're in our system, it is recorded.
Yeah, that's absolutely true for us too. But then if somebody has been provided with some information and advice that hasn't been assessed or isn't recorded on the system, we're not necessarily counting that. So we don't have a kind of gap between people who are kind of known as carers but not on our system that sits between the 900 and the 9,000. That gives out. In terms of the information and advice and the importance of that kind of came through very clearly right throughout all of the engagement with carers in the production of this strategy, and as you'd expect is kind of a key feature of what we've been tasked with focusing on over the next 5 years of its delivery, including in the strategy document itself, and like you said, and once published it will start to get out of date quite quickly, but as well as being a strategy document, it's got an appendix in it that has a colourful ream of contact information for different organisations that people can get in touch with, because that's carers told us they want to make it available here, as well as the specifics that are in the objectives here around the welcome.
Yeah, just a quick one, page 45. I mean, you mentioned here about the carers' concern around housing needs. Such as suitability, level of services also received from housing providers. I mean, if this is a huge problem, what have you got in mind to address this situation moving forward? Have you got anything in mind that's going to benefit the situation?
So we set up, so having heard this from carers, actually pretty worth mentioning that as we're producing strategies, we saw this with the LD plan in the previous item. One of the kind of main priorities that people tell us in co-producing these documents is housing, which actually in previous iterations of these sorts of things might not necessarily have been one of the kind of 6 key pillars. It really is coming through in all of the documentation, but something that as we co-produce it, people tell us is the priority. Specifically on housing, on page 58 of the agenda, where the strategy itself goes into some detail about what carers have asked us to think about to improve their housing situation, and that sets out 6 actions that we have undertaken to do over the lifetime of this strategy. So that I wouldn't read them out, but there are kind of 6 specific bins in there, and then as with each of these priorities that we've got for the strategy, there is also a section after that says how will we know whether we've done that work. So when we were writing this WISCAP, we said these are the things we want you to do, but we also want you to have a measure that. So there's a form of accountability. So the committees like this, but also ultimately being board, their local account group and carers forums, and ask us that question. But there are 6 key things that we've got then. So some of that includes
Is there a timeline to this? Is there a timeline?
so the strategy is a 5-year strategy.
Okay, so it's a fine.
Oh, yeah, but it won't be like we will have done everything by the end of 5 years.
Okay.
We'll do things sooner, and we'll have the regular sessions with the carers for to account for that.
Just going to quickly ask on earlier this week, we had a call with Brian and his colleague Sonia. Sonia flagged the fact that obviously these cafe and coffee mornings, and that they exist, I think, predominantly in the north of the borough and not the south, and just whether there's something we can be doing in terms of locations or being able to hold these in the south as well. Just we've spoken a lot about inequalities tonight, just that everyone has the same access, because there's not a sort of change in terms of the amount of carers in the north or south, but it sounds like there's a lack of space to actually have them. But I just whether is going to happen around that, so we can.
So I'm in touch with the property team here at the council, just to understand what is available, whether we can use the local authority property, or whether there are other community spaces that we can access in those areas.
It was a very, very quick one, just thinking about the carers allowance issue in particular, just because we know all the huge numbers when it comes to unclaimed benefits generally each year, something like 19 billion each year that goes unclaimed, and what data we have, if any, around care. We already know that there aren't enough people identifying as carers and getting the access that they need, just in terms of unclaimed carers allowance money that should be made available. How much isn't being claimed at the moment? Do we have an estimate for that?
We don't, other than taking on the basis of the data that's in here, which is quite broad. So if you took that census figure against the figure of people who are known to us and who are getting assessment, getting that data, that's the difference between 970 and 9,000. But if you took off the children's number, that would bring it down, but it's still a very big number in terms of the allowance that then need to be budgeted for. And that's money that comes from Department of Work and Pension through the council, so it's not direct council budgeting. But yeah, it's a big one.
So could we not go to the DWP and ask for that money and reinvest it in carers services?
It's a benefit and an assessment, so it's not money that's a demand service.
was just going to add it from the councillor. As a carer, I didn't register as a carer in order to get benefits. That's not why I did it, and that's not why a lot of people do it.
Sure.
And lots of times they're not entitled to benefits anyway. In my own case, it was because my only illness, as Sue said earlier on, if I'm taken to hospital, I need somebody to know how to deal with the person I'm caring for and act as a stepping provider almost immediately. Upon that happening. So there are lots of carers there that may never need access to grants or access to financial support. It's other support in inverted commas that are needed.
Thank you. And I also wondered if you could just speak about the discharge conversation we had earlier, and I think it's a very important one in terms of the pressures that's putting on carers as well. So that'd be
Yeah, so again, it's just my personal experience, and I don't live in this borough, so please don't worry. It's not a reflection on this borough. Certainly in my case, when my mother has regular falls and enters hospital, quite often she enters a discharge lounge and we're not told that she's been discharged. And therefore we can't make adaptations at home quick enough. And therefore, it places a pressure upon carers because, and certainly my experience with others as well, you're left in a position where you're not trained to carry out a medical process quite often, whether that's changing dressings or anything else. And there's a speed to move somebody on out of the hospital, and the pressure that places upon an individual who's untrained, unqualified, doesn't have the skills, and sometimes doesn't have the equipment to support the care for. It's quite significant.
I think from that conversation is, are we doing anything around, or are we hearing of carers struggling with discharge and added pressures? And is there any way of supporting them in that?
We have in each of our hospital trusts, as part of the discharge team, we have our social workers in there who help to make the discharge decision. And part of what they are able to do is to make sure that the appropriate consideration is given for circumstances at home and knowing when the care is there as well. But what Brian had been describing to previously is having either the health passport knowledge or the enhanced care plan or the social worker just know the case. Having those people embedded in the discharge team can make that a lot easier.
Yeah. My point of view, I went to visit the discharge team 2 weeks ago at the ones that we have at Chelsea Westminster. And I can't speak for other boroughs, but for what we do here, it works very well. Of course, there are still challenges around it with any form of discharge, especially peaks and troughs and all that. But our team, for example, will pre-ring ahead for someone who's being discharged, especially people who maybe live with a carer or live by themselves, just to ensure that their home is checked out. For example, when I was there, one I witnessed was a lady who was being discharged from hospital, but unbeknownst to anyone else, she was so working with that, but also our discharge team will then do a follow-up call about a few days later, just to see if the person's got everything they need or they need further help or anything like that. So there's that check-in element as well, which works really, really well. Again, I'm not sure how it may work for other boroughs, but that's something that we're certainly working towards. The carers that are integrated within the NHS staff that are based at the hospital as well. So I mean, it's really important that join those up together. As such, not 100%, but getting them that way. So that's something that's really helpful in that respect.
One more question, just one more. I'd like to know, what's the waiting time for adaptation? Disabled person home, what's the timeline for adaptation?
Generally it's very short. I mean, I can't give you one average figure.
From a point from A to B.
It can depend on the size of the adaptation that's needed. So if somebody needs a rail put in, and that can be done in a week. If somebody needs a wet room put in, that's going to take us.
Okay, so it's based on availability.
But and the scale of the adaptation. If it's a substantial change in someone's house, that takes an OT assessment, that takes time to get the equipment through and installed. If it's a relatively straightforward adjustment, that can be done.
Thank you.
Thank you very much, and thank you for this report, which I know is a huge amount of hard work into, and thank you guys for joining us today. Moving on to agenda item 7, adult social care complaints. The purpose of this report is to provide the select committee with an update on the adult social care annual complaint report for 2023 and invite questions about its contents. Staff council is to reflect planning disabilities and provided services, and Louise Butler, head of adult safeguarding, quality assurance and engagement, are here to present the report along with Josh Brengle. Thank you.
Thank you, Chair. Obviously, this report is extremely important because not only does it reflect our ability as a council, but the ability that our residents have and services have over the service that adult social care and public health provides. Now, there's nothing set in legislation that says you need to respond to a certain complaint within X amount of days. So we set ourselves as a council 10 days to reply to people with a complaint about the service they receive. But of course, adult social care is much more complex than perhaps if you have got your bin collected or your street hasn't been cleaned, which would be triggered in another part of the council, for example. That's not particularly complex cases. For adult social care, obviously, with the complaints that we receive, they can be very, very complex, obviously involving a lot of service users and a lot of other organizations, and how we can respond to that and step up to the mark to address those concerns. And as you can see, we try to answer as best we can complaints within a 10-day period, although sometimes they're a little bit longer as well, again, mainly due to the complexity of the situation of what we have. But as we said, we've got Louise and Seth here as well that speak about it in obviously certain more detail. But obviously, it's really important that the community looks at this. It's really important that, I also question the team on it as well to ensure we get the best possible results we can for our community, because this is very, very serious, and obviously we don't want to fall below the standards that we expect of ourselves, let alone anyone else.
I think that's Josh has covered that part.
Thank you for coming, and I'm sure we're going to question some of the figures in this report, as obviously we should be doing better. So I think just to start, what sort of plans you have in place to change the timeliness, in particular, that we are responding to complaints this year, would be really good to hear.
Absolutely. So the complaints team came underneath my team in September, and since then we've really put our foot on the pedal to ensure that we've made improvements. We've been looking at it underneath like a performance management approach, which means that we have regular weekly updates to ensure that those complaints are being pushed through. So we've done a lot of information and communication with our team managers, with heads of service, with directors, to make sure that they understand that these complaints open up a window actually on the service, so we can actually learn from where things have gone wrong. So we have also pulled it into performance management meetings monthly as well, and we've got some excellent data that comes through. So just by making a few tweaks here and there, and then little things around daily rotas, and we've actually dramatically made improvements in completion time of the complaints. So we're now been sitting at 100% since November, December, January. So we have made some really very good improvements.
That's really, really good to hear. And just to kind of dig into that a little bit more, what do you think did cause that?
So absolutely. So we've been looking at how come we were where we were, and how come we are now where we are. I think there's a few issues that we just needed to understand ourselves. So CQC is something that's really important to us. I think over the last year and a half we've been remodelling and looking at teams and how they've been operating, and we've been sort of having a look particularly within safeguarding quality assurance team. We recognise in fact complaints really ought to come into that team. Complaints, safeguarding and quality assurance all should be seen together. You shouldn't be isolating them. So I think that when we were remodelling also the whole of the governance arrangements that we had in place, we've now really got a really tight governance team. Complaints had to be moved across. So there was a time when it wasn't actually in the most appropriate team. And I think that's very simply, now it's there and we're moving forward and we're actually demonstrating that it's in the right place.
And one sort of bit linked to what you're just saying there, one area I did pick up on was that you said, well, that the report said a reason for timeliness can be due to the ability of key staff to participate in the investigation. And I was just wondering if is that a lack of that sort of support staff, or and then they're not free, or is there not enough senior staff in terms of that point?
Yes, I think that refers to what Kesh was saying about sometimes the complexity, because it could be multiple agencies, including CNWL, NHS, etc.
Yeah.
And sometimes bringing them all into the same space to deal with the matter can take time.
Yeah, just two really quick ones. I'm just looking at table 1 where it listed the proportion of the complaints that were
Page 76.
Thank you. Yeah, I appreciate it was only 3 complaints, which isn't a lot, but it looked as though there were, 100% of the complaints that were made to the learning disabilities team were upheld, and also the hospital social work team had a pretty high proportion as well. And were there any specific learning from those in particular? Because it's not just about the number of complaints, it's about the number that were genuinely upheld. And it looks like those 2 areas specifically were very appropriate complaints that were upheld. And then just in relation to that, obviously complaints are opportunity for learning, and what mechanisms there are to feed this information into actual learning.
Yes, so obviously complaints we take very seriously, and we take the feedback very seriously. And it can be a range of things. It could be things like the care provider coming in late or not being providing certain things at a certain time. So the learning would be around how we manage things to service, but also how we work with our partners like agencies, etc., just to make sure those mistakes don't get repeated, or those situations. So in those specific cases, it would be about making sure we've understood what was being said clearly, and then applying some kind of learning through the system so that's not repeated.
So is there like a mechanism that's used to review complaints or themes in complaints that recur with a learning event? Or
Yeah, so that's part of the quality assurance team does some of that in terms of quality assurance, what services are being provided, and then applying the learning through the services, so through the different care agencies and also the different teams as well.
That's one of the reasons why complaints come into underneath my area, because we've got a very strong learning culture, and we really want to push that out in terms of learning complaints, quality assurance and safeguarding. So there are systems in place for us to be able to do that.
Yeah, just out of curiosity, I'd just like to know how many of these staffs are contracted and who are from agency. Can I have a percentage of those, please? And based on complaints, if it hasn't been dealt with to satisfaction, what do you do to our residents as a result of that? And how skilled and trained are our workers at dealing with complaints?
First portion around how many of our social staff are contracted.
Yes, and who are in agency.
So for some of the 10%.
10% is contracted.
Yes, some of the 10%.
Okay.
I don't have the exact figure, but some of the 10%. And there's a full training regime that's provided for new staff as well as existing staff. So it's quite a lot of training provided throughout the year. Again, that sits under the vision.
Yeah, so in terms of training, you need to have great listening skills. You need to be incredibly sensitive and understanding, very patient. So the complaints team have all that training in place, and ongoing mentoring and coaching as well. So every single service user makes a complaint. We pick up the phone, we talk to them, or we go and visit them face to face, and we support them because the complaints team is neutral. We support them through the complaints process. as the teams are gathering information, and they're investigating what the actual complaint is. So they're well supported through that process.
So are there any incentive if a complaint is not dealt with to satisfaction? And after it, do you reflect on how that could have been dealt with better?
We reflect on pretty much every single complaint that comes through, regardless if it's upheld, partially upheld or not upheld. And we reflect on it because it's important that we are transparent in what we do, and we are we empower our service users to actually challenge decisions that are made, and the Care Act is very clear about allowing service users to do that. So yes, that's part of our learning process and part of the learning culture, which is to learn from the incidents that have occurred, what's gone wrong, to make sure it's gone right. And that's why the quality assurance team is so key, because they go in and they'll support providers and to actually ensure that their systems and everything are much better than they were before.
Thank you. Jump in on that in terms of also from what you're saying, is there a positive culture about when things go wrong, admitting that we have got it wrong rather than being defensive? Because I think that's
right.
I feel that's what you're saying.
I promote a no blame culture.
Yeah.
However, it's very easy for me to say that, isn't it? So there's an awful lot of nervousness when things have gone wrong.
Yeah.
But it's about promoting a no blame culture and saying, look, we know things have gone wrong. What we're here to do is not hit you over the head, but let's try and work out how, A, we're not going to make that happen again, but what can you learn from this experience? So there has to be a certain amount of reflection within that.
Yeah. So I think that's very healthy, and I guess that partly comes from staff feeling not worried to let you down and feel comfortable enough to
a certain extent.
Yeah.
I did have 3 questions, but you answered 2 of them. Basically, I only got one. The figure of 34% of complaints regarding quality of care probably actually slightly off the sound, and probably more a question of Josh to answer rather than you. But it seems to be an incredibly high, I mean, I realise they're low numbers, but incredibly high figure. Do you think it sort of points to a wider problem?
No.
Quality of care?
I don't think so. I think that people sometimes hope to have very valid complaints. That's absolutely. I think the team here work. I mean, there's always things you can do better, and that's in any organisation at all. But sometimes these people's complaints can be complex, not just involving us as well, can be involve other services of the council, which may not be as good as ASC. I completely take that on board, especially in housing, where there is a challenge. But I think the team does their best to strive and go above and beyond what that is, and I've witnessed that out there in the community myself. But of course, things may, as I said, not always go perfectly. But I don't doubt for a minute there's a wider culture where things aren't working. As I said, there may be 1 or 2 things that we can improve, absolutely, but I disagree. That's certainly the case with what I've seen of our staff. They're very, very committed. They are extremely passionate about the work they do. When I've seen all the teams out there in the communities, from people in care homes to people in hospitals to people going to people's homes in the community, everyone that I've seen has done an exceptional job, and I think I'm really pleased and glad that. That's my opinion. That's my 2 cents. But
pretty much covered. I was just noting that. Thank you. We got 92 complaints, but from 79 people, and I wonder whether there were 1 or 2 who are complaining a lot about many things, or whether that's just an expected number that people will have a couple of complaints in a series. And you might not know those particular cases, but I just thought it's interesting if you're getting a few multiples.
You do get some people who complain on a multiple basis, a serial complainer. So it's really understanding what that's about, and that's what that figured in.
But I look very positively and say, well, actually, it's a very, very difficult area, and 96% of people are not complaining. I know you don't want any complaints, but for something that's so complex and so difficult, it's not a simple solution to the issues that you're looking at here. Then that's still a positive.
Yeah, and just to pick up what Josh was saying, in fact, the data is reducing. So now we've got a much stronger quality assurance team in place. With that 32% is actually reducing 32%. And in fact, the whole referrals for complaints is reducing as well. And that's happening nationally as well, because we know the quality assurance processes and systems so much tighter than now than they used to be.
Any other questions? Portia, did you have another question?
I do, but we're out of time.
Right, thank you very much for coming and in particular the work that we've done too. That's really positive. So that's great to hear. I hope, yeah, that'd be.
Thank you very much.
Thank you, Chair. Moving on to agenda item 8, the work programme report. This report is an update on the work programme and scrutiny activities setting out. Reports received in the I never know how to say that word. Yeah. Is the committee happy to agree the report as tabled?
Yes.
Well, I just checking the dates in 3.2, is that 2024?
Let me get to it.
24, and in 3.3, that's.
Oh, it is 2024, cool.
And it's 3.3 as well, 24.
So our next one is.
Yeah,
So the next committee meeting.
Yeah.
So that does indicate.
Let's go back to 23. Yeah, but also in 3.3, it's will now begin in summer 2024. Yeah, it's really how far I got in my detailed reading.
That concludes this meeting. So thank you to everyone.
Thank you, Chair.
Exactly that.
Well done. Yeah, it's because that first report only got added
Quality of the councils.
last week. Yeah.
You take your picture of the